Welcome, and thank you for standing by. At this time, all participants are in a listen-only mode until the question-and-answer session of today's conference. At that time, you may press star 1 on your touch-tone phone to ask a question. I would like to inform all parties that today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the call over to Dr. Jacqueline Miller. Thank you. You may begin.
Thank you, Sheila. Welcome, everyone. We're glad to see that you've joined today's webinar on understanding the new American Society for Colposcopy and Cervical Pathology Consensus Guidelines. As you're all aware, in March of 2013, the ASC-US released their new consensus guidelines for management of abnormal cervical cancer screening tests and CIN. Today we have Dr. Stewart Massad, who co-authored the 2001 and the 2006 ASC-US guidelines and was the chair and meeting author for the most recent guideline update. Today's presentation will provide an overview of the updated consensus guideline and the scientific review. Dr. Massad is a professor in the Division of Gynecologic Oncology at Washington University School of Medicine in St. Louis. His career has focused on cervical cancer prevention, and he has also worked on assessing relationships between HIV-induced immunosuppression and cervical cancer and cancer precursors. Dr. Massad received his medical degree from Duke University in Durham, North Carolina, where he also completed his residency in obstetrics and gynecology. He trained in internal medicine at Albany Medical Center in Albany, New York, and completed a fellowship in gynecologic oncology at the Washington University School of Medicine in St. Louis. Dr. Massad earned his Bachelor of Arts degree at Williams College in Williamstown, Massachusetts. Dr. Massad, we'll turn it over to you, and thank you again for agreeing to do this presentation.
Thanks for inviting me. Thanks to all of you for joining on the call. As part of full disclosure, I think I should say that that picture is now more than 5 years old, and as a result of doing these guidelines, I have a lot more gray hair than is in the picture. This is the introduction slide, so we can skip that. I have no financial ties to industry. I used to work at Cook County Hospital and have tried to keep free of at least financial ties, although I do talk to industry people. At the conclusion of this session, all of you should be able to apply risk-based principles to the selection of management options for women with abnormal cervical cancer screening tests and CIN and adenocarcinoma in situ of the cervix, and you should also be able to individualize management for younger women who are at lower risk of cancer. When you think about guidelines, you should keep in mind the goals of screening. The goal of cervical cancer screening is always to prevent morbidity and mortality from cancer. It's not about finding CIN or abnormal PAPs or HPV, although we do think that prevention works because we're able to identify and destroy cancer precursors before they actually go on to become malignant. So it's important to find CIN and abnormal PAPs and sometimes HPV, but that's not actually what we're trying to do. The goal is to try to keep people from dying or suffering from cervical cancer. It's also important to keep in mind that preventing all cervical cancer is really an unrealistic goal, and trying to do that would be harmful. Cervical cancers in the youngest women may not be screen detectable, and if we were to try to approximate even total prevention, we'd have to have a very high sensitivity screen, such as HPV testing. We'd have to screen with that high sensitivity test at frequent intervals, and we'd have to treat for the most equivocal, usually transient abnormalities. The assessment of the consensus panel was that trying to strive for preventing all cancer would result in harms to women that far outweigh the potential benefits of cancer prevention. Harms from screening that have been shown are stigmatization, disrupted relationships, and anxiety and distress that result from a diagnosis of a potentially precancerous condition, especially when linked to HPV detection, which is a sexually transmitted infection. There's always the lost time, expensive investigation for lesions that are destined to regress that may come from finding an abnormality that would otherwise have gone away on its own. For those of you who do colposcopy, you know that it's not particularly pleasant, and treatments can be associated with even more pain and risk of injury. But the harm that really impressed the consensus conference participants most was the issue of pregnancy loss. It seems clear that the more the cervix is destroyed, the more the risk for future pregnancy loss occurs, and we'll be talking about that more somewhat further down the line. But you don't want to try to strive for 100% cancer prevention and then destroy enough cervix that you have an increase in preterm delivery with all the morbidity, mortality, and misery that can result. When we think about targeting screening, we don't want to wait until women have cervical cancer. We know that CIN3 is an ideal target. It's thought generally of as precancer, although in the few studies that have been done, now considered unethical to try to replicate, only about 30 to 50% of CIN3 lesions that were identified progressed to cancer over a 30-year period. That's a lot of people developing cancer, but it's still not 100%. We can't observe people. It's not acceptable to do that these days because we don't know which CIN3s will become invasive and when. Some may actually be associated with an invasive cancer at the time of diagnosis. Some may sit stably as CIN3s for decades, but we can't distinguish between those, so we always target CIN3 with screening for treatment. CIN2, on the other hand, is a collection of CIN3 and CIN1. It's useful as a community threshold for assigning treatment, but it does have a more than 50% regression rate and a very low risk of associated invasion at that point in time without progression through CIN3. Regression risk is probably even higher in younger women. So for that reason, you'll see in some of the management algorithms, observation appears to be acceptable, especially in younger women. CIN1 is generally considered now no longer truly neoplastic. It's most likely a transient or stable HPV infection with minimal cancer risk and is not treated except insofar as it may cause abnormal cytology and people having to keep coming back for reassessment. Treatment in those cases may truncate the need for repeated colposcopy, biopsy, ECC that keep coming back CIN1. Treatment certainly will speed clearance of HPV infections in those women, but it doesn't have much of an impact on cancer. One new concept to introduce when we talk about ASCCP management guidelines is that we're trying to tailor the interventions following a screening test based on the risk of high-grade dysplasia, especially CIN3 and worse. Triaging patients into various risk groups, and we'll talk through that in somewhat more detail as we go on. But certainly in patients who are at high risk for developing cervical cancer, we want to destroy the transformation zone through a variety of treatments. Women who are low risk would have to go back to routine screening, and then there's a variety of intermediate risk levels. I'm getting a message that I don't need. There are a variety of intermediate risk levels, and we manage women by the level of risk that's associated. So if it didn't look like treatment was needed, but you had an intermediate level of risk for developing CIN3 or even cancer, you might call the woman back for a shorter interval rescreening. You also might consider doing molecular triage. For a long time, we've been doing triage for ASC-US using HPV-related molecular tests. We now can do genotyping for HPV types 16 and 18, and some sites can do P16 testing with women who are positive for P16 being triaged to more aggressive intervention, and people who are P16 negative being triaged to short interval rescreening or even back to routine screening. And the traditional triage modality to try to assess risk is colposcopy with biopsy to try to identify those women who have CIN3 or worse for treatment and those who don't for observation. Keep in mind that definitions of high, low, and intermediate risk are pretty arbitrary. I've been asked to go to Ethiopia at the end of May. They would have a much higher risk for intervention on a community basis. A resource-rich country like the United States would have a different, much lower threshold for what's high risk and would require treatment. So the definitions of high, low, and intermediate risk are not fixed for the next century. They're a community assessment based on balancing the risks of intervention against the risks of cancer in the context of what the community resources for cancer prevention might be. The Previous guidelines were based on expert assessment of risk. There were 1994 guidelines that were published in JAMA that were based on an expert panel that just kind of made up guidelines based on what we knew of the natural history of CIN and the associated risks of disease based on various grades of Pap testing after the 1991 Bethesda system revision. In 2001 and 2006, ASCCP held consensus conferences that incorporated the data from the ASCUS LSIL triage study and formal literature review. Oops, somehow, I guess I better keep the cursor off those arrow buttons. That incorporated ALTS data and formal literature review to come up with the guidelines that we've been familiar with for most of the last decade. These were used to identify current risk thresholds for current guidelines. So pretty traditionally, we've thought that somebody who has HPV-positive ASCUS or low-grade SIL would go to colposcopy, and CIN2 is the agreed-upon threshold for treatment. Once we have more information based on various combinations of tests, we can work from these consensus intervention risk thresholds to try to come up with similar interventions for similar levels of risk. And this slide helps us to think about that. The risk of cervical cancer or precancer condenses a battery of tests to all one number. Using the concept of similar management of similar risks ensures simplified, consistent management of different test combinations. And the 2012 guidelines that we'll talk about today build off implicit risk thresholds in prior guidelines. That's a lot to think about. So we'll try to walk through that relatively slowly. The guidelines are based on big data. So there's the Kaiser Permanente of Northern California Health Group has collected information on screening results and cervical outcomes for almost 1.4 million women, and this database was queried for the Guidelines Development Conference. There are more than 1 million women ages 30 and up who have co-testing results, and among those, there were over 400 cancers, more than 3,000 CIN3+, and almost 8,000 CIN2+. There were also almost 400,000 women ages under 30 who had cytology and only had HPV triage for ASCUS, so they didn't have co-testing because of their young age, given current screening guidelines. There were only 26 cancers in that lower risk group, although there were 1,200 CIN3+ and over 4,000 CIN2+. So this is the database that was used to develop a lot of the figures that we'll be looking at during the course of today. Computer analysis of that data allow fairly precise risk estimation for various test results and combinations. So we were able to ask the statisticians, what are the immediate and future, generally 5-year risk of CIN2+, CIN3+, and cancer after X, and you could fill in anything you wanted for X. So it could be after an ASCUS PAP, after a HSIL PAP, after a biopsy of CIN1, after a combination of ASCUS PAP followed by CIN1, and we'll see what some of those curves look like. Generally, CIN3+ was the data endpoint that we tried to use for comparison of different batteries of test results, but we did use CIN2+ for rare events in which there were few CIN3+ events, and sometimes we assessed risk for cancer even when the CIN2-3 risk was relatively low, as after an AGC PAP. When the real meaningful endpoint was cancer, then that was what we focused on. We tried not to be too rigid. There were some limits to this data set. Even with 1.4 million women, you can't define the management of rare events. I work with the Illinois Breast and Cervical Cancer Program. We've been asked if someone has HPV-negative ASCUS and then they come back later and have a repeat HPV-negative ASCUS, is it still safe to watch? And the answer seems to be yes. If they come back a third time and still have HPV-negative ASCUS, when do you do colposcopy? Well, there were so few women in the data set that we couldn't come up with meaningful risk estimates for those. Another issue is that although the database is very large, it's not at all clear whether this is generalizable to all U.S. women. We think that it probably is, but it's not going to be precise. Women with higher or lower levels of various risk factors such as multiple partners, smoking, early age of first intercourse, oral contraceptive use may have somewhat different levels of risk, but it seems that if we benchmark to standard intervention levels from the 2006 guidelines, that we should still be able to work to other populations. But we did say in these guidelines that we have to individualize, and you can't just apply guidelines everywhere. You have to have some rationale, though, for why you might not generalize. We did not look at 6-month assessments. That wasn't part of the way these women were followed, so we can't really tell you whether shorter interval testing would have led to benefit or not. The margin status at cone or leap wasn't recorded, so we couldn't do any information or give any risk estimates based on those. And the database only extends 8 years, so we can't tell you what to do over the longer term. The hope is that by the time we get to the longer term, we'll have more information. But for example, if someone is treated for CIN3, they're supposed to have a co-test at a year, another co-test a year later, and another co-test 3 years later. So what do they do if all those 3 are negative? What's their risk at 10 years? We can't answer that. So there are some pathways that really can't tell us when women get to risk low enough for routine screening at this point. And some of the pathways just end at 8 to 10 years. In that case, it would have been 5 years. So this is a way of thinking about risk, and it shows the stars show the various levels of risk of cervical precancer or cancer defined as CIN3, AIS, or cervical cancer on the left side. And you'll notice that the y-axis is geometric up to the break, so that if we had this all as an arithmetic scale like it is above the break, the differences would be minimal, but it's geometric, so you can pull those apart. Generally, for women who are PAP negative and are only getting PAP testing, it was agreed that return for 3-year PAP is standard. That's the way the 2012 screening guidelines played out. And most of this talk assumes that you're familiar with the American Cancer Society, ASCCP, ASCP screening guidelines, or the U.S. Preventive Services Task Force guidelines that were fairly similar. This is from Hormuz Katki, who was presenting to a group that doesn't really talk Bethesda. So equivocal is ASCUS. The risk after an ASCUS PAP result is about 2.6% for CIN3+. Those women can be managed with a 1-year callback. Women who are low grade instead would get a biopsy. Women who are high grade have a much higher risk of disease. So given these thresholds, I think that skipped a slide. We do HPV triage for ASCUS, which is the square box over here, and you can see that the risk is similar to the risk of an LSIL PAP. So they should be managed similarly with colposcopy. In contrast, HPV negative ASCUS has a risk that's close to a negative PAP, so those would be managed similarly. Keep in mind that it's somewhat higher risk than we thought when HPV negative ASCUS was discussed in 2011 in the guidelines for screening published in 2012. It seems to be too high for a 5-year callback, and these new management guidelines suggest that those patients who have HPV negative ASCUS come back in 3 years rather than 5 years. The HPV positive PAP negative risk in this column over here also differs based on whether the patient has an HPV test or not. And you can see when they're co-test negative, the risk for disease by 5 years is very, very low, which has led to the 5-year return recommendation. In contrast, someone who's HPV positive but PAP negative is close to but doesn't quite meet the threshold for biopsy. And the feeling at the consensus conference was to require all those women to come back for colposcopy would be an undue burden to the colposcopy system. So the recommendation is for those women to come back for co-testing again in a year. That's that slide. This is another way to think about benchmarking implicit risk thresholds. This shows you the years since enrollment, and this is the cumulative risk of CIN3. So you can see that HPV-negative ASCUS is somewhat higher than women who have a negative PAP by itself, and so should be managed in a similar way. That's how they came up with the idea that these women should be managed at 3 years. The consensus from the screening conference was that women who were PAP negative and had no HPV co-testing would be screened at 3-year intervals, and so we do the similar thing for HPV negative ASCUS. HPV positive ASCUS has an immediate risk of 3.2%, which is greater than LSIL, which we do colposcopy for. So these patients all get referred for colposcopy. And I just talked about HPV negative ASCUS. We now use 5-year risk for all risk thresholds. For each comparison, one group is riskier than the other group at all times. Immediate colposcopy has a 5-year risk of about 5.3%. Up here, the 1-year return has a 5-year risk of about 2.6%. So when the 5-year risks are about this, they'd have a 1-year callback. If the 5-year risk is about this, then they'd come back at 3 years. Oops, that skipped a slide. So this is a slide that shows you that the thresholds are not rigid numbers, that we manage people based on bands of information. So 5-year callback would be for women who are co-test negative. The 3-year return would be for people who are PAP negative. This is the group that has cytology only, and this is the group that has co-testing results. So 3-year return would be for women who are PAP negative or had HPV negative ASCUS. A 1-year return would be reasonable for women who had ASCUS and no HPV triage, for women who are HPV positive and PAP negative, or for women who had HPV negative low-grade SIL. We'd ask for immediate colposcopy for women who had LSIL with no HPV test, and those who had HPV positive ASCUS and HPV positive LSIL. The risks are somewhat higher, but it seems to be a reasonable band here. And then you have significantly higher risk for women who have these higher grades of PAP abnormality or women who have these various combinations of HPV and PAP abnormality. We'll see it again later, but you can see here that women who have HPV negative HSIL still have a substantial risk of CIN3 over time, and the same is true for women who have HPV negative ASC-H as well, although it's not as high as for women who have low SIL. Keep skipping slides for me. There were additional things besides the availability of the Kaiser Permanente of Northern California database. One big driver was the 2011 American Cancer Society ASCCP, and it's left out, but the American Society of Clinical Pathologists screening guidelines changed expectations. We're now doing more co-testing. How do we manage discordant co-tests? So what do we do with HPV negative ASCUS, HPV negative LSIL, HPV negative HSIL, and HPV positive PAP negative women? How often is routine screening? That changed with the new guidelines on screening. And how should we manage adolescents? There used to be ASCCP guidelines for management of adolescents, but adolescents shouldn't be screened anymore. Should we be screening a different subgroup of young women, or managing a subgroup of women with PAP abnormalities differently and similar to the standards that we introduced in 2006 for adolescents? There are also new data on PAP spread as unsatisfactory or as having no endocervical or transformation zone component. I know this has been a big bone of contention, at least in Illinois, because the old guidelines called for most of those women to come back in a year for rescreening. Those were never really validated in a consensus conference. They were developed by the Pathology Committee in ASCCP. So we thought we'd actually review the data on that and discuss it in a conference and vote. There are new data on outcomes of CIN1 when it's specified on ECC, and then we have new technology with new options for management, especially HPV genotyping. There are likely to be other technology advancements that change the molecular testing that are available to try to come up with different risks for having CIN3+, but those are considered experimental at the time of the consensus conference. We may have to have a new conference down the road, but at this point, HPV genotyping is really the only technology that's changed what we do. A word about the Consensus Development Conference process. ASCCP created 6 working groups through its practice committee. They addressed issues that we had defined. The working groups were led by the ASCCP practice committee co-chairs and by national experts from the National Cancer Institute and the community. We then went out to more than 20 professional societies, federal agencies, and U.S. international cancer prevention organizations. CDC was included and sent several delegates, although they, for their own reasons, are not co-authors on the paper. The working groups were then assigned various questions. They met to address and discuss those questions in Bethesda. That should be 2012. It's not 2013. And all recommendations were accepted by a more than 2/3 vote. And we'll go through what those guidelines are soon. Keep in mind, as I mentioned, that these guidelines are based on best available evidence. High-quality evidence is not available for all questions, but all questions that seem to require a clinical guidance were addressed. Some of those are based only on expert opinion and may be subject to change at a future meeting. And guidelines should never substitute for clinical judgment. They can't apply to all clinical situations, and you have to use judgment in applying guidelines to specific situations. A caution on HPV testing. There are 4 different FDA-approved HPV tests. There are others that are available to pathologists to use in their labs, and some labs have in-house assays. The consensus was that recommendations on use of HPV testing are based on controlled trials using validated HPV tests. You can't assume that you'll get similar results when you do management based on results of assays that are not similarly validated, and you may either over or undertreat patients depending on whether your test is too sensitive or too specific. And the consensus was that labs should only use HPV tests that are validated to ensure reproducibility and accuracy in identifying defined cancer precursors as documented either by FDA approval or peer-reviewed publication. It's not acceptable to use the guidelines for results that have HPV tests reported that have not met those criteria. And the consensus also is that there's no role in cancer prevention and probably anywhere else for low-risk HPV testing. Why don't we do HPV testing alone as a screen? The currently available HPV tests lack a mechanism for assessment of squamous cellularity, and a negative test may be falsely negative if there were insufficient cells. You may be falsely reassured that there's nothing going on when you just didn't get a good enough sample. The concurrent PAP done at the same time in a co-test controls for cellularity. It's also something that people are more familiar with. HPV testing is not FDA approved as a standalone test, so we couldn't really recommend something that wouldn't be available to clinicians. That said, I would guess that over the next decade or so, we will see other countries moving to primary HPV screening, and we may do the same. But the guidelines are not based on HPV testing as a standalone without a concomitant cytology result. And a mention about treatment in pregnancy. I've said that one of the big concerns about harms from overtreatment is that women with LEAP are more likely to have preterm birth, low birth weight, and premature rupture of membranes. Other studies that are smaller have shown some association with perinatal death or incompetent cervix. It's helpful that we've had similar results from other modalities besides LEAP, including cold knife conization and laser conization. Some things to keep in mind when thinking about the terminology that you'll see. When we talked about a guideline that's recommended, there's only really one option that's available. When there are more than one options, one may be preferred when it's best or one of the best against multiple options. Others may be acceptable, or if there's none that's superior, favoring any single option, they'd all be acceptable. In the past, the only other option was unacceptable. When there was good data against use, there's now a new term that we use for some recommendations, which is that something may be not recommended. That means the evidence against it is fairly weak and the option doesn't carry much risk, but it seemed like it was not a very good idea rather than something that was straight out unacceptable. How did the guidelines change? Many of you have been using the 2006 guidelines for several years. You'll want the highlights. So women who have cytology negative results with adequate satisfactory assessment but lack endocervical cells or transformation zone component can be managed without having to be called back for an early repeat. Women who have CIN1 clearly defined on endocervical curettage can be managed as CIN1, not as a positive ECC. So those women are usually followed rather than treated. Unsatisfactory cytology will require a repeat even if it's HPV negative, and we'll talk about that below. And then genotyping triages HPV positive, HPV 16-18 positive women. That's a dash linking these two. That's not 16 negative. So either 16 or 18 positive women to colposcopy only after negative cytology. There are some papers out suggesting you can do it for triage of women with HPV positive ASC-US, but the consensus was that the risk was too high for women who were HPV positive, 16, 18 negative, and they all still needed colposcopy. Other changes from 2006 for ASC-US, immediate colposcopy is not an option. There used to be three options. One was HPV triage, another was repeat PAP at 6 and 12 months, and the third was immediate colposcopy. The risk seems to be very low now, and immediate colposcopy is not an option. The serial cytology option for ASC-US now says to wait 12 months for changes to regress, not 6 and 12 months as it was in 2006. And then they go to cytology every 3 years. We'll see that algorithm down the line. And then HPV negative ASC-US results should be followed with cotesting at 3 years rather than the 5 years that was recommended in the screening document from last year. And then we clarified that HPV negative ASC-US is insufficient to allow exit from screening. Keep in mind that women can stop screening at age 65 if they have 3 negative results. We thought HPV negative ASC-US is a pretty low risk result, but it's not low enough to get people out of screening at age 65. And then the third slide on what changes we'll see, the pathway to long-term follow-up of treated and untreated CIN2+ is more clearly defined and incorporates cotesting. In fact, overall, more strategies incorporate cotesting to reduce the number of follow-up risks. PAP-only strategies are now limited to women less than 30, but cotesting is expanded even to women younger than 30 in some circumstances. The reason that there are not PAP-only strategies for older women is that although there's a screening option for women 30 and up with only PAP testing at 3-year intervals, the thinking was that when abnormalities come out, those patients will be referred to places where PAP tests with HPV testing should be available. They should have a somewhat higher level of sophistication and should be able to get co-testing done. And then women ages 21 to 24 are managed conservatively. There's not a guideline for how to manage women under 21 with abnormal results because they shouldn't be screened. But the understanding is that you can manage them using the 21 to 24-year-old algorithm if they should be screened inadvertently. So what are the guidelines themselves? Well, we'll start with unsatisfactory cytology. That accounts for about less than 1% of all PAPs. With liquid-based cytology, it usually results from not enough cells on the slide. Some HPV tests lack squamous cellularity control, as we mentioned, so an HPV negative result is unreliable when the PAP is unsatisfactory. You can't tell if you have actually got cells. What I tell my residents is that you can't know if the nurse picked up the empty vial or the correct vial when you forgot to label the vial immediately after getting the Pap test. And you may have an empty vial that comes back HPV negative, unsatisfactory. Those patients need to get screened again because there may just not have been cells in the jar. The CIN3 risk after HPV positive unsatisfactory cytology is also unclear. So for women of any age who are HPV unknown or HPV negative, the Pap should be repeated after 2 to 4 months. There are some pathology studies that suggest that a cervix that has been scraped needs a couple months to eliminate reparative changes. If she's known to be HPV positive, there are 2 acceptable options. You can either bring them back in 2 to 4 months, and if the Pap is abnormal, you manage the patient according to that. If the Pap is actually negative, then you can do routine screening if they're HPV negative or unknown, or you can do co-testing in 1 year if they're HPV positive, as you would for a Pap negative HPV positive result. If you have 2 consecutive unsatisfactory Pap results, then the recommendation is for colposcopy. And if the woman is 30 and up and has an unsatisfactory HPV positive result, there is the option of going direct to colposcopy. For women who are Pap negative but have no endocervical cells or transformation zone component, that occurs in 10 to 20% of Pap. So it's a fairly significant burden on the system. These are slides that are missing endocervical or metaplastic cells. Most cancers will arise near the squamous-columnar junction, and it's not clear if all areas at risk have been sampled. But in studies that have looked at these women, the risk for CIN3 is actually not greater in follow-up, suggesting that lesions were not missed. HPV results seem to be valid and independent of whether the transformation zone was adequately sampled. In other words, a negative HPV result has good negative predictive value regardless of whether you got endocervical cells or not. Based on that, this is the algorithm that we work with. If the Pap is negative for intraepithelial lesion or malignancy but lacks endocervical cells or a transformation zone component, or it's insufficient for assessment and they're young, they can go to routine screening since there's not really a reason to do HPV testing for those women and they're pretty low risk. If their age is 30 and higher, and they're known to be HPV negative, then they go back to routine screening. They have a negative co-test result, and their risk is quite low. If the HPV test is unknown, then HPV testing is the preferred strategy. And if it's negative, they go to routine screening. Or if they're HPV positive, then they can have co-testing in a year or genotyping, and then they get managed according to that guideline. It's also acceptable to just follow with a Pap in 3 years if they're HPV unknown. So the bottom line is that most of these women will go to routine screening and they don't have to come back for a 1-year repeat anymore. For women who are Pap negative but known to be HPV positive, that would occur in about 5 to 10% of co-tests among women in the age group where you're supposed to be getting co-testing. The CIN3 plus risk is higher than after a co-test negative result, but the risk is insufficient to justify colposcopy for all, as we saw when we looked at some of those risk stratification graphs from the National Cancer Institute earlier. The risk is higher if the patient has persistent HPV positivity and justifies colposcopy. Women who have HPV 16 or 18 are at particularly high risk of CIN3. Despite a negative Pap, it's about 10%. HPV 18 is linked to adenocarcinoma, which is sometimes linked by sometimes missed when the patient only has a Pap. So if you're trying to drive down actual cancer rates, then quick follow-up for someone who's HPV 18 positive would be important, although their CIN3 risk is less than if they had an HPV 16 result. This shows that we're playing against the clearance of HPV and the risk of disease. So this is the likelihood of the repeat. HC2 is the proprietary name for the HPV DNA test. You can see over the years the likelihood of persistent positivity falls. When patients were HPV positive, Pap negative at baseline, The risk of cancer stays pretty low across time. The risk of CIN3+ increases fairly linearly. So you want to give the lesion time to regress, and you're unlikely to have cancers develop over a year of follow-up. These are 5-year risks among women who are of co-test age after an HPV-positive PAP-negative result. And you can see that across the various ages, the risk of cancer stays about the same. CIN3 risk falls some, except in the oldest age group, and the same seems to be true for CIN2+. The likelihood of repeat positivity at 1 year is 50 to 60% across all these age groups. So you'll get rid of about 40% of positivity by watching across time. Thinking about genotyping, there are both DNA and mRNA tests available. The prognostic information seems to be similar, though not exactly the same. Again, the 5-year risk of CIN2+ for HPV-16 is over 10%, and we talked about how HPV-18 is associated with adenocarcinoma. The ASC-CP guideline does not recommend for or against genotyping. There's a pathway for what to do if you and your clinicians decide that that's the direction that you want to go, but doesn't say that genotyping is a preferred path or a recommended path. It's an optional path, and we provide information if you decide that you want to do genotyping, but that's a local decision, and ASC-CP doesn't have a guidance about whether you should or should not be doing that. It may also be a budgetary decision that you may decide to make. So this gives you an idea of what the CIN3+ risk is for patients who are PAP negative, 16 positive, 18 positive, other things positive, and who are PAP negative, HPV negative. So the risk at 10 years for somebody who's co-test negative is extremely low. The 16 risk rises fairly quickly and continues to increase across time. There seems to be something of a lag for HPV-18, but it still is significant across the years. So that's why 16 and 18 appear clearly different from non-16, 18. This is a group where you can just see how they come back a year later and only do colposcopy if they have a persistent abnormality. So for women who are 30 and up who are PAP negative but HPV positive, it's acceptable to do repeat co-testing a year later with colposcopy only if they're ASC or worse or HPV positive. Questions come up, well, what if they're HPV negative? Ask us. They're probably not at very high risk, but we didn't want to make these algorithms even more complicated by having subcategories here. So if the PAP is abnormal in any way, even if the HPV has gone negative, they go to colposcopy. If they're co-test negative, then they repeat the co-test again 3 years later. We don't have enough information to go to routine screening for these people. This is one of those cases where we just didn't have enough numbers at a distance in time. The other option is to do HPV DNA typing for type 16 or 18. If they're positive, they get colposcopy. If they're negative, they still may have one of the other high-risk HPV types, so they get repeat co-testing in a year. And if they're abnormal, then these groups get managed according to the relevant guideline. How to manage ASC-US, that's about 5% of all PAP tests. Between a third and two-thirds are HPV associated. HPV testing is about 95% sensitive for CIN2+. The specificity roughly doubles to more than 60% if ASC-US is managed with HPV testing. ASC-US patients are more commonly HPV positive when younger or when those patients have new or multiple partners. And it's been shown in previous papers that HPV triage of ASC-US is more cost-effective than just following PAP tests across time. This I already talked about. Removing ASC-H from ASC-US in the 2001 Bethesda revision decreased the risk for CIN3+. The risk in the Kaiser Permanente database was significantly less than the risk that was previously reported in ALTS. For women who are over 60, the cancer risk after HPV-negative ASC-US was greater than after a co-test. So we required retesting in less than 5 years in contrast to the 2011 screening recommendations. And the CIN 3 plus risk for HPV positive 1618 negative ASCUS still requires colposcopy. So there wasn't thought to be a good utility to genotyping for ASCUS patients. They go to colposcopy if they're 1618 positive, and they go to colposcopy if they're 1618 negative. Since it doesn't change management and increases cost, it doesn't make sense to do 1618 testing for ASCUS. This gives you an idea of risk for CIN 2 plus and CIN 3 plus for patients who have ASCUS, and it shows how HPV negative ASCUS has a CIN 2 plus risk and a CIN 3 plus risk that's similar to that of PAP negative women, whereas the HPV positive ASCUS has a risk that's similar to that of LSIL. So we manage similar to those results. It appears that in the oldest women, ASCUS has a higher cancer risk compared to negative PAP results. That's this blue line here. So HPV negative ASCUS still has a relatively higher risk of cancer in the oldest age group. It's still not dramatically high. So even if they're HPV negative ASCUS here, this is thought to be a fairly substantial difference, and you would not consider to let women who are HPV negative ASCUS, who had HPV negative ASCUS as their most recent result, to consider that as a negative result and allow them to exit from screening. So even if they're HPV negative ASCUS at 64, they still need to continue to be followed until they meet criteria for exiting. Here's how we manage women who have ASCUS, either 1-year repeat cytology, not at 6 and 12 months as in the old guidelines, colposcopy if that's ASCUS or worse. If it's negative, they go to routine screening. Since this is assumed to be done only when there's no HPV testing available, that would be cytology in 3 years. The preferred management is HPV triage. If they're negative, then you do repeat co-testing in 3 years rather than 5 years. That's different from the 2012 screening guideline because, as we've shown, they have higher risk than the co-test negative women. If they're HPV positive, they're managed just like women with LSIL with colposcopy. And then the further management depends on what the colposcopy shows. For women in this youngest age group, the risk of cancer is pretty low. It's about 1 in a million for adolescents under 20. For women in the 21 to 24-year-old age group, it's still only about 2 per million. There are only 3 cancers in 133,947 women that they followed over up to 8 years. 1 had HPV positive ASCUS. There were no cancers in the women who had LSIL. HPV risk is peaking at this time, so the likelihood that you'll have an abnormality is relatively high. The likelihood that they may want to go on to get pregnant later is also high, and this is the age group in which more than 50% of women will have their CIN2 regress if that's what you find. LSIL among women in this age group, the 5-year CIN 3 plus risk was only 3% after ASCUS and LSIL. It was only 4% after an HPV positive ASCUS. That's pretty low. Both are significantly lower than for older women. The 5-year CIN 3 plus risk was only 0.6% after HPV negative risk. That was close to, but 3 times higher than the risk after a negative PAP result. That means that HPV triage really doesn't alter management much, and you shouldn't do it in this young age group. So here's the guideline for women ages 21 to 24 with either ASCUS or LSIL. The recommendation is to repeat cytology at 12 months. This is preferred. We recognize that some sites, especially with ASCUS results, will have a direction to their lab to do reflex HPV testing and won't distinguish 21 to 24-year-olds and break them out separately. If they're known to be HPV negative, they go on back to routine screening. If they're HPV positive, then you just repeat the PAP in 12 months. So if an HPV positive ASCUS result in this age group does not lead to colposcopy, it just leads to 12-month repeat cytology. If they're ASC-H, HSIL, or HSIL, if they're one of the higher risk PAP abnormalities at the 12-month visit, then they go to colposcopy. If they're negative ASC-US or LSIL, then you repeat 12 months later. They only go to colposcopy if they have persistent abnormality across. This would be 2 years of follow-up after their initial ASC-US. If they're negative twice, then if they're negative here and they're negative here, then you go on to routine screening. How to manage low SIL. That's about 2 to 3% of cytology specimens. Low SIL and HPV-positive ASC-US have similar SIN3 risk. About 75% of low SIL are HPV positive. That's too many to efficiently use HPV triage, although it was understood that in some centers the risks are less because of potential biases in age distribution. Older women are more likely to be HPV negative with low SIL, or there may be differences in the threshold for diagnosis of low SIL across different labs. If it's less than 50%, then HPV triage may be useful, but it doesn't appear to be generalizable enough to be a standard that we could ask people to apply nationally. So generally, HPV triage is not done for low SIL. When women are found to be HPV negative low SIL, when they have cotesting, they get a PAP result and an HPV result. Some of those will have HPV negative low SIL. The CIN3 plus risk at 5 years was only 2%. 67% of low SIL patients will have HCIN1 or just HPV effect at colposcopy. The risk of cancer in this group is quite low, suggesting that you don't have to, not intervening aggressively in this group will not result in missed cancers. This is a figure similar to the one that we've seen that looks at CIN2 plus and CIN3 plus risk in women of cotest age across time. This is the low SIL group. HPV positive low SIL and low SIL act similarly. HPV negative low SIL acts similar to ASC-US that's not been HPV triaged. So the concept of similar management for similar results suggests that you should have similar management based on HPV results. So now, in contrast to 2006, we have a variety of different low SIL and HPV test combinations. If you know you have a negative HPV test, the recommendation that's preferred is repeat co-testing in a year, but it is acceptable to do colposcopy for those women, as it is for those who have no HPV test or who have a positive HPV test. They all go to colposcopy. If you've gone to LSIL with a negative HPV test in the 30 to 64-year-old age group, then the recommendation is for repeat co-testing a year later with colposcopy if they have an abnormal PAP or are HPV positive. If they're co-test negative, then you repeat the co-test at 3 years. The risk was low, but was not as low as in patients who were co-test negative to start with. So there's not a return to routine screening in this age group. And we'll talk about what to do with colposcopy results after low SIL. How to manage atypical squamous cells cannot rule out high grade. That's pretty rare. It's only about 1 in 200 PAPs. But when we're screening 40 million women, there'll be a substantial number of those results. The CIN3 risk at 5 years is 18% in the Kaiser Permanente of Northern California database. More than 60% were HPV positive. HPV triage is relatively inefficient in this group. When they're HPV negative, it's not low enough to do just routine follow-up, and when it's positive, then they have a fairly high risk of disease. This shows you various combinations for CIN2 plus, CIN3 plus, and in this case, what concerned us was cancer risk. For ASC-H patients, they have a cancer risk similar to that of AGC. The CIN3 plus risk was intermediate between these lower grade PAP abnormalities and high SIL, both for CIN3 plus and for CIN2 plus. So for everyone who has ASC-H, they all get colposcopy. If they have a co-test, they get colposcopy if they're HPV positive or negative. And we'll talk about the guidelines for what to do with the biopsy results after colposcopy. For women who have these more aggressive or riskier results on cytology when they're in the youngest age group, the risk is clearly higher for CIN3+ than if they had ASCUS or LSIL. It's 28% after HSIL, 16% after ASC-H, and 7% after AGC. Keep in mind that the concern with AGC is not so much CIN3 as it is adenocarcinoma and cancer, which are rare but potentially devastating in these younger women. The 5-year cancer risk was only 0% for HSIL, 0% for ASC-H, and 1% after AGC. So cancer is unlikely despite extended observation in these women, especially if they have a negative colposcopy. So if you have one of these concerning results like ASC-H or HSIL, they all get colposcopy. There's a separate guideline for AGC. You don't do immediate excision, which is an option for women who are older. If you have no CIN2 or 3, then those women are observed at 6-month intervals for up to 2 years. If they have a high-grade colposcopic lesion that persists for a year, they get biopsied. If they have CIN2-3 developed, then they get managed for the CIN2-3. If they have HSIL that persists for 24 months and everything's negative, then you should do a diagnostic excision. If they have 2 negative cytology results and no high-grade abnormality on colposcopy, then they go back to routine screening, which would be perhaps every 3 years. Other results get managed according to ASC-CP guidelines. This is the algorithm that applies to women who have, there'll be another slide that looks at women 21 to 24 who have negative or CIN1 after ASC-H and HSIL. That is under revision, and this is the guideline that's the correct one. How do we manage HSIL? It's again about 1 in 200 pap tests. Peaks in women in their in their 20s. About 90% are HPV positive, so there's not really a role for HPV triage. CIN3 plus risk is 36%, 47% at 5 years, and that justifies immediate excision when pregnancy is not really an issue. 6% of women in the co-test group will have cancer on further evaluation of a HSIL. That's a lot. HPV, when HSIL is found in co-testing, 35% of women with HPV negative HSIL have CIN2 or worse. That's almost 50% at 5 years, and by then 7% of those women will have cancer. So that clearly deserves further assessment. You can't do HPV triage. I think we mentioned that 90% of HSIL will be HPV positive. That means 10% will be HPV negative. You still have to do further investigation of those, whether they're HPV positive or negative. And again, the risk is quite high, especially over time. So they need assessment. The green arrow is HPV negative HSIL. The red arrow is HPV positive HSIL. You can see how the risk is pretty high and increases across time, regardless of whether you use CIN2, CIN3, or cancer as your endpoint. For patients who have HPV positive HSIL, they have a very high immediate risk for CIN2+, and those are patients who you might consider just doing CIN loop excision for if you don't consider it for all your patients with HSIL. HPV negative has a lower immediate precancer risk, but a rising 5-year precancer risk and a similar 5-year cancer risk. So you have to be very careful with those people. The rationale for immediate excision for women with HSIL is that the prevalence of CIN2-3 is high. Most will require excision later. Requiring extra visits for colposcopy can impair compliance, especially if they don't like the procedure and the pain that's associated with biopsy. It certainly will increase cost if you go to loop excision anyway. The sensitivity of colposcopy appears to be suboptimal. In all, it's only 54% of CIN3 were found at intake colposcopy, although, of course, the ASCUS LSIL triage study by definition did not include patients who entered with high-grade PAPs. Why not to do immediate excision for women with HSIL? There is a significant, roughly 40% likelihood that they'll either have CIN1 or no lesion. That's truer in younger women. Some of the women who have CIN2 would see those resolve if you never treated them. Again, that's truer in younger women. Once colposcopy excludes cancer, progression to cancer in the short term is pretty uncommon. Again, that's true in younger women. In special circumstances, how to manage HSIL. Colposcopy in pregnancy is complicated by vascular and epithelial changes that accentuate normal and abnormal findings. It's very difficult to do colposcopy in pregnancy. Biopsy can result in discomfort, cost, and bleeding that can be significant. You really can't do a second biopsy because of the bleeding risk. Failure to do biopsy, though, has been associated with cancers that didn't show up until postpartum or intrapartum. The risk of cancer postpartum is much less than 10%, and most recent studies suggest that's fallen over time. Some of the studies that look at this are pretty old. Many oncologists follow pregnant women who have a stage 1 cancer to viability, so CIN3 or 2 are probably reasonable to follow. A missed microinvasive focus next to the area where you did only one biopsy is probably not clinically significant. So this is a very simple algorithm. If you have a patient who has HSIL, they either get treated right away or they get colposcopy with endocervical assessment. And then the results of the colposcopy depend on whether CIN2-3 is found or if it's not found. And there's variation in what to do, whether the patient's 21 to 24 or pregnant. Immediate excision is not permitted if the patient's pregnant or ages 21 to 24. How do we manage AGC? And we're getting towards the end of the cytology section of this. AGC counts for about 1 in 500 Pap tests. It's subdivided into AGC not otherwise specified, which can be endometrial, endocervical, or just glandular. AGC favor neoplasia patients. More than 30% have CIN2+, which that's read as frankly adenocarcinoma in situ. More than half of those will have histologic AIS, and more than 30% will have cancer. Subdivisions were not analyzed in the Kaiser Permanente data set, so we don't have differentiation of these 3 types. Most women with AGC actually have a squamous abnormality, not adenocarcinoma in situ. How do you use cotesting? HPV results can direct evaluation. There's a more suspicion of endometrial disease if they're HPV negative, especially if they're older, obese, or oligomenorrheic. You still have to look to exclude cervical lesions, though. If they're HPV positive, they're more likely to have a cervical or endocervical lesion. The cancer risk by 5 years if they're HPV positive AGC is 9%, which is tremendous, much higher than, or somewhat higher than HPV positive HSIL, which was 7%. Since initial management isn't affected, cotesting is deferred till follow-up. So HPV results don't change the initial management of AGC. This shows you that the risk of CIN is low if the patient's HPV negative, though they still have to be evaluated, especially because endometrial lesions remain a significant concern. How do we manage AGC patients initially? If you have atypical endometrial cells, you can do endometrial and endocervical sampling, and if there's no endometrial pathology, they go to colposcopy. If you don't have this subclassification on your Pap report, then they all go to colposcopy with endocervical sampling, and endometrial sampling is done if the patient is 35 or older or at risk for endometrial neoplasia, including unexplained vaginal bleeding or conditioning suggesting chronic anovulation. What do you do after that initial colposcopy? If there's no CIN2+, AIS, or cancer, then they get co-tested at 1 year and 2 years. If both of those are negative, then you co-test 3 years later. There's not a strategy here to get to routine screening because at the end of the time period in the Kaiser Permanente data set, they still were at high risk. If there's any abnormality, including HPV negative ascus, they still go to colposcopy. If the initial cytology is AGC favor neoplasia or AIS, even if you don't have a lesion that's identified at the time of your colposcopy, they still need a diagnostic excision procedure. If they're CIN2+, but no adenocarcinoma in situ, then those are managed according to the ASC-CP guideline for whatever you found. There's a separate guideline for how to manage AIS. So what do you do with biopsy results? There's now a slide on how to manage less than CIN2, so negative or CIN1 found after lesser abnormalities. It was too cumbersome to put all the lesser abnormalities in the title of an algorithm slide, but that includes women who are PAP negative but 16/18 positive, PAP negative but who are persistently HPV positive. They're supposed to come back in a year for co-testing. Say she was PAP negative HPV positive at time 0 and at 1 year later, then those patients would be considered to have lesser abnormalities. ASC-US and LSIL are also lesser abnormalities. Despite the use of atypical in ASC-H or AGC, those patients do not have lesser abnormalities. Those are major abnormalities and should be managed more aggressively. The risk for co-test results are always higher after an initial abnormal result. So even if you get a negative result, those patients don't have the same likelihood, the same low risk for CIN3+ over time as if they'd come in initially with a negative co-test. It's difficult to get to routine screening after an abnormal PAP, even if one co-test is negative. The 5-year CIN3+ risk after 2 consecutive PAP-negative HPV-positive co-tests is 7.4%, higher than after baseline LSIL. The 5-year CIN2+ risk is 16%. This was CIN3+, that's CIN2+. Genotyping results are not available in the Kaiser database, so I won't be able to confuse you with more aggressive or more convoluted algorithms based on how to use genotyping results in follow-up. After a negative or CIN result at colposcopy, the immediate risk of precancer is low, but surveillance is still required. You can see how that shaped up. Those are the red arrows that play out across here. You still have to keep those patients in surveillance. Most of the CIN2+ by 5 years are CIN2, which may or may not be true precancer. So women who have no lesion or biopsy-confirmed cervical intraepithelial lesion neoplasia grade 1 after lesser abnormalities that we just defined can be followed without treatment. They get co-testing at 12 months. If they're co-test negative, then they get age-appropriate retesting. If they're less than 30, that would be PAP testing. If they're 30 and up, then that would be co-testing. If they're PAP negative, and if they have an HPV test based on their age, and that's all negative, then they're cleared for routine screening. If they have any abnormality, then they go to colposcopy. And then there are guidelines for what to do here. If they have persistent CIN1 for at least 2 years, then you do have the option of treatment. You can use ablative or excisional methods. Excision is preferred if colposcopy is inadequate, which is the new IFCPC term that we use instead of satisfactory, if they're CIN2 or worse on ECC or if they were previously treated. I have 20 slides left. If they have CIN1 or negative after one of these more major PAP abnormalities, the 5-year risk of disease remains high despite not finding a high-grade lesion on colposcopy. Keep in mind that the sensitivity of colposcopy is limited. The sensitivity goes up with the number of biopsies that are done, up to about 4. This is not really the forum to talk about how many biopsies to do, but more biopsies appear to be more sensitive, although patients may not appreciate them. The risk of CIN2+ after HSIL is 24% at 5 years, despite having negative or CIN results on colposcopy and biopsy. The risk of CIN2 or CIN3 is low after an AGC result when the colposcopy shows nothing, shows no ectocervical lesion or CIN1, but their cancer risk is still high enough that we consider this a major abnormality. This shows AGC, ASC-H, and HSIL. Likelihood of CIN2+ is 34% after HSIL, 16% after ASC-H, and only 5.5% after AGC. So these groups need special attention. The concern with AGC is the dramatically higher risk, 10 times higher for AGC compared to HPV-positive ASC-US or LSIL. So after a negative or CIN result at colposcopy and biopsy, the risk seems to rise relatively rapidly, especially for these two groups. That's reflected in the algorithm. So if there's no lesion or CIN1 after ASC-H, HSIL, or AGC, then you can do, there are several options. You can do cotesting. You can do a diagnostic excision procedure off the start, or you can do a review of cytologic, histologic, and colposcopic findings, and if the diagnosis changes, then you manage according to that. If you do cotesting and the patient has 2 consecutive negative cotests, then the risk is quite low, and the patient can go to 3-year cotesting. That would be, can go to 3-year age-specific retesting, which would be PAP if less than 30, or cotest if 30 or higher. If you have any abnormality, then you go to colposcopy, except if you have HSIL followed by HSIL, then you can't watch that. Those patients have to have a diagnostic excision. Less than CIN1 in the youngest women, there's a near zero cancer risk in this group. Missed CIN is unlikely to result in harm in the short term. We think CIN3 may take decades to progress to cancer. Over-treatment of lesions that are likely to go away on their own can harm future pregnancies. The potential for harm to future pregnancies means that we would do more conservative management for similar risks. Remember that the overlying principle here has been that we tailor risk so that similar risks are managed in similar ways. Because of the potential for harm to pregnancies, we'd actually be more conservative here than we would in older women. A 5-year CIN3 plus risk after ASC-US LSIL with less than CIN2 plus in this age group was about 3%. The risk would be lower after prevalent lesions were found. 5-year CIN3 plus risk among 21 to 24-year-old women with HSIL was 28%, and with ASC-US was 16%. But again, you have eliminated some of those results by your colposcopy after HSIL. So what to do after a CIN1 or negative result in this youngest age group, don't pay attention to this. It's going to be resolved, and that would be you'd manage these patients based on the algorithm for ASC-H or HSIL in this age group. After ASC-US or LSIL, they get repeat cytology at 12 months and then 24 months, and they go to routine screening if both of those were negative. There's not co-testing in this. If they were ASC-H or HSIL, they'd go to colposcopy. They'd also get colposcopy if they had ASC or worse at any of their serial PAP testing. Or, I'm sorry, if they had persistent abnormality across 2 years. I don't know when ASCCP is going to upload the replacement for that slide. It may be there now. It should be there certainly by the end of April in the PDF at their website. How to manage CIN2-3, about 43% of CIN2 will regress, 35% will persist, and only 22% will progress. That is to CIN3, not to cancer. Unfortunately, with CIN3, many will persist across time, but some will progress, and more depending on how long you follow people. We gave higher numbers based on long-term natural history studies that are not ethical. That's the kind of intermediate-term risk. How do you manage CIN2-3? How do you think about that? Randomized trials show similar outcomes with about 10% failure risk after ablation or excision. Ablation being cryotherapy or laser, excision being cold knife cone, laser cone, or LEAP. Excision does have the advantage of providing a histologic specimen. In randomized trials, LEAP has a shorter operating time and less bleeding than knife conization, but does give you more margin artifact. You can't do ablation unless cancer has been ruled out. So the ECC has to be negative, colposcopy has to be adequate or satisfactory, and you have to have no suspicion of cancer by PAP or colposcopy. And because of the risk of skip lesions, if there was previous treatment, then you have to do excision rather than ablation. This shows risk of recurrence after treatment of CIN2 plus among women who are 25 and up. If they were treated for CIN2, the risk is less than if they were treated for CIN3 or AIS. And this is, you can see how the risk differs depending on the antecedent PAP. So if they had minor abnormalities, then they have a lower risk, although This rises to 8.2% at 5 years if they'd had previous CIN3. If they had a more severe major PAP abnormality, the risk for recurrence is 16% if they had CIN3 or AIS. It's 10% if they were treated for CIN2. Follow-up after treatment, most recurrences will present within 2 years. Among 2,240 women who were followed after CIN treatment, 3/4 occurred in the first 24 months. Recurrences can be seen, though, 20 years and more after treatment. That's only been shown in the Scandinavian centralized data registries where they can really follow the entire population for decades because they're all enrolled in the socialized medical system. But we think that CIN23 is the same disease no matter which continent you happen to be living on. So we want to do fairly intensive surveillance initially, but the risk seems to be higher over the long term as well. These are the papers that looked at HPV testing on treatment failure rates. The patients who were HPV negative had fairly low risk of having persistent disease, whereas those who were HPV positive were much more likely to have had persistent disease. So the negative predictive value of HPV testing is reasonable. That's incorporated into our follow-up strategy. So women who have CIN2-3 and an adequate colposcopy can have either excision or ablation. If they have inadequate colposcopy, recurrence, or a positive ECC, then they get a diagnostic excisional procedure, either LEAP or cold knife cone. And then they're followed with co-testing at 12 months, 24 months. If both of those are negative, then 3 years, and then routine screening after that. So if you have 3 negative co-tests, you go to routine screening, which would be 5-year co-tests, but they never stop screening, at least not for 20 years. If any of the tests are abnormal, then you go to colposcopy and endocervical sampling. Management is different if the woman is pregnant or young. If you have a positive margin, then ECC cytology at 4 to 6 months is preferred, but you can do repeat excision, and hysterectomy is acceptable if you can't do re-excision. For example, if there's not enough cervix left to re-excise. In young women, there was a request after the 2006 guidelines. Who are young women? What's the age cutoff? There's not an age cutoff. Young women, for the purposes of management of CIN2-3, are not considered those 21 to 24. It's not that you have to treat every woman 25 and up. Young women are those who can, after counseling by their clinicians, consider the risk to future pregnancies from treating abnormalities to outweigh concern about the risk for cancer during observation of those abnormalities. There's no specific age threshold that's intended. So a 23-year-old who's been sterilized isn't young. Her concern about future pregnancies is going to be nil, and her cancer risk would be dominant. A 38-year-old who's in treatment for incompetent cervix may still be considered young according to these guidelines, although, as we'll see, she has to have a satisfactory or adequate colposcopic assessment. This is managing young women based on that definition with CIN2-3. Either treatment or observation is acceptable provided colposcopy is adequate. If CIN2 is specified, then observation is preferred. If CIN3 is specified or colposcopy is inadequate, then you go to treatment. You can observe, if you elect observation, it's colposcopy and cytology every 6 months for 12 months. When you have 2 negative PAPs and normal colposcopy, then you do a co-test in a year, and if that's negative, then it's co-testing in 3 years. If either test is abnormal here, then you repeat colposcopy and biopsy is recommended. Same if the colposcopy worsens or you get high-grade cytology developing or the colposcopy persists as abnormal for a year, despite having only CIN2-3. If the CIN3 is found at any point in time, or if you have CIN2-3 that persists for 24 months, then treatment is recommended. How to manage AIS that's found at excision. Cancer has to be excluded by cone. You can't diagnose adenocarcinoma in situ based on a biopsy. Knife or a large loop should aim for intact specimen with interpretable, preferably clear margins. You should not be doing top hat leaps for patients who are known to have adenocarcinoma in situ. The lesion can occur deeper in the canal. It's difficult to see colposcopically. You don't want to do a top hat loop excision and find out that the brim of the top hat extended right through the lesion and it's got heat distortion and you can't diagnose whether she has cancer or whether the margins were clear. The risk of persistent adenocarcinoma in situ after colon with clear margins is about 10%. A few patients, but not many, will later develop cancer. A negative HPV test is a strong predictor of clearance of AIS. A word about margin status. Among 110 women who were followed after colon for AIS, 55% with a positive margin, but only 23% with a negative margin had persistence at hysterectomy. Keep in mind that hysterectomy would select for women who didn't want to have childbearing in the future and who might have had more aggressive or larger lesions. Only 7% recurred among 560 women managed conservatively. Only one of those had an invasive cancer. The risk of a positive margin was lower after a cold knife cone than after LEAP, although they do make big LEAP wires now that are 2 by 1.5 or 2.5 centimeters, so you can get essentially as deep with a LEAP now if you choose your instruments correctly, but you have to be careful to use a really large LEAP, and many people are uncomfortable with those. So management of women with AIS during a diagnostic excision procedure. Hysterectomy is the preferred management. We showed that the likelihood of recurrence, even with clear margins, is substantial, but if they really want to get pregnant in the future, conservative management is acceptable. If the margins are involved or the ECC after the LEAP or diagnostic excision procedure is positive, it's recommended that they get re-excised to get clear margins. It's acceptable, though this made everybody nervous, to do reevaluation at 6 months. If the margins are negative, then you follow them over the long term. And that wasn't specified. There was an ASC-CP pathology consensus conference, we're getting close to the end, that talked about how to report biopsy results. I've forgotten what LAS stands for, but it eliminates CIN2 as a diagnosis. Women either have low-grade SIL or high-grade SIL based on biopsy. CIN3 is high-grade SIL. P16 is used to try to figure out whether your CIN2 is low-grade or high-grade. If it's positive, that's high-grade. If it's negative, that's considered low-grade. CIN1 that is suspected of maybe being CIN2, the atypical cells go close to they're a third of the way up the thickness of the epithelium. You're not sure if it's high-grade or not. Then you can use P16 testing. And P16 negative or not tested CIN1 is considered low-grade. Unfortunately, this is a new classification system. There's very little evidence base for determining how these various abnormalities behave over the long term, and the guidance should be considered preliminary. But if all your results are low-grade or high-grade on your biopsies, what do? Well, if it's read as low cylinder last, then you should manage them like CIN1. If they're high cylinder last, then you should manage them like CIN2-3, which does allow for conservative management. And this is, so I know this is confusing, this is for histopathology results, biopsy results only. For more information, the whole text that explains the 29 pages of the document is available in the Journal of Lower Genital Tract Disease. That same supplement has all the background Northern California Kaiser data analyses on which this was based. The algorithms are available for free download, although you can't change them at asccp.org at their consensus site. Finally, I'd like to thank all the people on the Guideline Steering Committee, Mark Einstein, Warner Ha, Hermuz Kaki, Walter Kinney, Mark Schiffman, Diane Solomon, Nicole Swensenson, and Herschel Lawson, who's also the ASC-CP medical director, for all the hard work that they put into developing this. And I think after an hour and a half of listening to me talk, it's time for questions.
Thank you. We will now begin the question and answer session. If you would like to ask a question, please press *1 Unmute your phone and record your name clearly. I will require your name to introduce your question. If you need to withdraw your question, press star 2. Again, to ask a question, please press star 1 and record your name. It will take a few moments for the questions to come through. Please stand by. Our first question is from Michelle Brulin. Go ahead, your line is open.
Incredible talk, thank you. I have a couple of questions, but the biggest one has to do with the terminology of talking about routine screening after someone has an abnormality. And I think I understand why you all chose it, but I think it in the end is kind of confusing. Probably follow-up or some such, because as we all know, once someone has an abnormality, technically they're not being screened anymore.
That's true, but we wanted to get people back to the routine screening concept in the American Cancer Society or the U.S. Preventative Services Task Force routine screening guidelines. And routine screening is shorthand for go back to the standard screening for people who are not at high risk. Makes
sense. I've gotten a lot of questions about it, though.
It's technically an error, but spelling out, go back to the 2012.
Yeah.
These are confusing guidelines. There are too many words on them already.
Yeah.
So that's the idea.
I got it. My other question was, I wonder if there was consideration given to making, and I realize this may look worse, but in the end I think it would be easier, one set for 21 to 24, one set for 30 plus, and then the other.
One set of what?
Well, certainly for the screening ones, because there's a lot of them that have a blue box, right?
Yes.
Management may differ, and so I've gotten a bunch of questions about that too, even though there's a separate one.
You can print the PDF and shuffle the algorithms any way you want.
No, I know. I'm just reflecting what I'm getting questions about already.
Right.
Lots of good work.
We broke them out, but how you sequence them in your head is really more dependent on how your head works.
Yeah, that's true.
Anything else?
No, great work. I know it was really tough to do all this.
Thanks.
Our next question is from Wesley Prater. Go ahead, your line is open.
Yes, what is the benefit of ECC? Is there a benefit when you're doing the evaluation of a patient with mild dysplasia, moderate dysplasia?
Depends on whether it comes back high grade or not. The likelihood of getting a positive result depends on the grade of the PAP, the age of the patient, and whether it's an adequate or inadequate exam. I don't have the guideline in front of me, but I think if the exam is unsatisfactory or inadequate, then it's recommended because you don't know if there's not something higher grade up inside. If you have a satisfactory assessment, then it's not required. It's more a matter of judgment. Some people do it because there's a tendency to consider it useful to get random biopsies to try to increase sensitivity for CIN3+, and the ECC can also function as a random biopsy. But I think it's only strongly recommended or preferred if the colposcopy is unsatisfactory.
Thank you.
Our next question is from Sharon Bisner. Go ahead, your line is open.
Yes, hi. We have some laboratories that are reporting LSIL cannot rule out high grade on cytology, and asking whether your recommendation is similar management to ASC-H.
That's not clear. There aren't good studies on that, and it wasn't available in the Northern California Kaiser database. The labs that report that diagnosis have their LSIL patients have about a 25% likelihood of having CIN2+. So they certainly need colposcopy. The bigger question is whether you can do HPV testing on LSIL when those labs have that diagnosis, because well under 10% will have CIN2+ if you carve out the LSIL-H patients. But I can't really answer your question based on what we have. My personal inclination is I'd treat them all just like low-SIL. Hello?
One moment, please.
Okay.
Our next question is from Gloria Powell. Go ahead, your line is open.
Hello, this is Gloria Powell, and I have a question that has come up here in Connecticut, and we are not screening women for cervical cancer who are aged less than 21 years old, but I'm wondering if there is any recommendation for screening women who are positive for HIV or who have another immunocompromised condition, for instance, transplant recipients?
There is a CDC guideline on opportunistic infections that recommends starting screening for HIV-positive adolescents at the time of HIV diagnosis or when they're sexually active, whichever is later. So if you've got somebody who's HIV positive from birth but isn't sexually active, then she wouldn't start screening till 21. Whereas if you had somebody who acquired HIV through heterosexual transmission at 18, she would start getting screened. But whether programmatically you would cover that or not, I think is a bigger question than I can answer. Fundamentally, though, the guidelines are different for HIV-positive women, and the CDC owns those guidelines.
We are showing no further questions at this time.
Sure, they'll come up later. Okay, are we done?
I think that is it, Dr. Stewart. Thank you again so much for taking the time to go through and giving us such a detailed explanation. And if anyone's on the line has any follow-up questions, you can feel free to send them to your program consultant here at CDC, and we will funnel them to Dr. Massad.
The one caution I would give people is to reprint the PDF of the guideline or review the PDF of the guideline on the ASCCP website toward the end of April, beginning of May. We're doing some tweaking of wording, although with the one exception of 21 to 24-year-olds with negative or CIN results at colposcopy after ASC-H, HSIL, there aren't any that are wrong. We're just trying to clarify language. So look at the guidelines to try to see if they've been further clarified end of April, beginning of March. And check out the JLGTD supplement if you want to know more about risk assessment.
All right, thank you. We'll watch for those guidelines, and we will try to send out a link to all of our programs once those guidelines are released to help everyone out.
There probably won't be an announcement. It'll just kind of be as people have lots of questions, we'll tweak to clarify what the algorithms say.
Okay.
The fundamental guidelines won't be changed, so the text document won't be altered.
Okay. Sounds good.
Okay. Thanks, everyone.
Thank you so much.
Bye.
That concludes today's conference. Thank you for participating. You may disconnect at this time.